No, it's going to be recorded.
My name is John Cohen. I'm with Science, and this is a question for Dennis Malvi. One question I had was what you thought of your data being leaked early and what impact you think that had. And the second question is the trial doesn't have a randomized control design. It has a historical control. And I wonder whether you think it's going to be able to yield data that can be applied widely through West Africa at the end of the day.
Yes, the way of conducting such trials in so difficult conditions, as my colleague also explained just after my presentation, are to the really difficulty to apply usual comparative and randomized trials. And though proof of concept pilot studies already can provide early data for, first of all, reappraising the natural history of the disease and the way to better assess our therapeutic strategies. And as soon as we are conducting these evaluations, we are also able to try to implement the level of the standard of care in the different centers where this kind of evaluation is to be conducted. And mainly, we ensure all my colleagues and investigators and clinicians that such data can provide strong information to conduct future trials that maybe could be also adaptive and using different strategies. Some models are to be applied in the very next future, not formally randomized, but with a kind of capacity for comparison, using maybe standard of care plus a promising antiviral drug to be compared with other ones, more expensive or more difficult to be applied immediately.
Could you answer the first question I asked too? And to put a fine point on what you're saying, what it sounds like is you're saying that the data from your trial, I don't want to put words in your mouth, but it sounds like what you're saying is you don't anticipate that those data will lead to widespread use of favipiravir, but will lead to more studies of it. Is that right?
Exactly. Yes, to continue our trial, we are still continuing the trial to strengthen the first data we have provided and to also seek the future for the way for other evaluations and the best way for implementation at a nationwide or over countries-wide place.
The first question I had asked was about the leak and what you thought of that and what impact. I'm assuming it didn't come from you. So if you want to clarify it did come from you, that's fine too. But
yeah.
What do you think of the leak?
The news, the New York Times article.
Oh, yeah. I'm sorry, I didn't firmly. I stayed in the scientific proposal. Yeah. Well, we are in a very specific and hard situation, both on the field. I'm first of all a clinician and investigator on the field, and we have to adapt to very specific, difficult, and tremendously surprising events. Well, the way then used in the first dissemination of these very, very early data have not strictly depended of the investigators. And we will try as much as possible to reinforce the clarification of the results we really find in our presentations, in our contacts with colleagues, and surely in the presentation which will be given in the CROI conference.
Okay, let's move on to other questions.
JeanDaniel Fauci, French TV. The Ebola crisis is a very good example of what public health is. It's 10% medicine and health and 90% of other things, as John just underlined for the moment. I would like to have your feelings, both of you on the field. Is it still possible to do good science and good clinical trials with the pressure which has been put first by the French authorities, leaking the results, and now by the president of Guinea, which wants the drug for everyone? And in these three countries, the presidents have been poorly elected. They are running for re-election. Capitals are gathering the most of the population. Is there a chance to get decentralized access to care, or as these elections are coming up in at least two of these three countries, isn't it a risk to see the capital cities being favorized and a lot of people just let on the road because the voices are in the cities?
So, Gilles, do you want to take that first?
I mean, yeah, luckily in Liberia, the elections are over. They were in December. They didn't massively interfere with the response. In Guinea, they are interfering with the response very severely. We think that part of the increased aggression is due to organized misinformation campaigns. So to answer your question, yes, I think it still will be possible to have a decentralized response. It is definitely being complicated by the political processes. In Sierra Leone, I cannot really comment. I haven't heard as much political interference as there is in Guinea.
Tinley, do you want to add anything to that? Or?
Yes, thank you, Scott. Well, I do agree with Gilles, and both as clinicians and investigators have to strengthen our partnership to stay in the most simple and efficient way, both for care of patients to contribute to the reinforcement of the contact surveillance and for providing in the most peaceful situation our own job for conducting evaluating procedures. It's not difficult, but it's possible if we are all working in the same direction and strengthening our partnership. And I can testify and acknowledge that the link we built with Médecins Sans Frontières, with ANIMA, and all other very impressive NGOs who are conducting a fantastic job is a proof and a guarantee for conducting our job in the most convenient and fruitful conditions.
Please.
Ed Sussman with the MedPage Today. Dr. Malvi, I just wanted to get some specific numbers on the people in the two groups. How many people overall are you reporting on at this meeting, and how many in each group?
Okay. At the moment, the JICI trial enrolled 108 patients by the end of February. The early data we will present, which are accounting for baseline and preliminary findings, have been analyzed upon the first recruitment of patients between last December until mid-January. They account for 80 patients. And among this group, upon 69 adult and adolescents, Ebola virus disease patients. 69 adults and adolescent patients.
How many are in the advanced disease group and the
Yeah, all these details will be provided on Wednesday presentation.
I'm going to write it today.
Yeah.
So I don't have an eye in the future. So how can you tell us how many patients are in each group?
In each group.
It's my understanding that the embargo lifts after the press conference.
Yeah. It's written in the abstract, and you have both the proportion and the absolute numbers of patients in each group according to CT viral load.
Question?
Hi, Marilyn Marchione from the Associated Press. I wondered, Dr. Malvi, if you could tell us if there was anything different about the care that these patients received versus the patients treated previously, like more supportive care, anti-malarials, any other factors that could have influenced the survival rates. And it's a well-known fact that mortality declines as epidemics go on, at least in previous Ebola outbreaks, and even in this one, there was a study in New England Journal in December from Sierra Leone showing declining mortality. So how do we know that this drug was making a difference at all, even in this small cohort? And my other question or request is if the others on the panel could comment on the results so far and whether they think there is anything that we should be concluding from them.
Okay, so the first question was relating to the standard of care proposed for the patients in the sites where the trial was implemented. Well, the sites where the three main important centers where the trial was implemented were located in Highland, Guinea, with exactly the same procedures, both for the laboratory procedures, both for standard of care, which accounts for nutritional care, antibiotic, antimalarial treatment, and pain treatment. That was one of the main important issue in our methodological approach. It is that we can have strong clinical informations and biological informations in the very next immediate, in the very last immediate period of the 2.5 and 3 months preceding the implementation in the trial in the same sites. And concerning the decrease of the mortality rate between the beginning of the epidemic and the time we implemented the trial, this fall was more marked between the period between March and July and August, and between the period of during the period between August and November, which accounts for the period concerning the pretrial time, the mortality was not different. So this we can be rather comfortable for the comparison between the rate of mortality during the trial and during the immediate period preceding the trial.
David, do you want to comment? And Gilles, just briefly?
Yeah, I mean,
Yes, well, I am not actually working in Ebola treatment trials, so I cannot
Okay.
compare that.
Gilles, quick comment?
no, I think Denis presented the results relatively well. MSF is, considers this as positive preliminary results that need further investigation, because before we can draw more firmer conclusion, it's unfortunate, of course, that there seems to be very little impact on the most vulnerable patients, which are the ones with high viral loads and children.
So this may be the last question.
Hi, I'm Marcus with IFR TV,
Yeah.
and my question is for Gilles. What is MSF's plan for treating zones that are affected by Ebola that are resistant to treatment?
You mean in terms of community
Yes.
resistance? I mean, community mobilization is mostly a question of persistence and of giving the right messages using anthropological approach. So it's to continue what we've already been doing, but it is difficult it is getting more difficult in Guinea, and what we will do with the political processes that I can't tell you yet. We'll have to be flexible again.
Thank you.
Okay, this is the
This
last
is
question.
the last question, yes.
I just wanted to bring this whole thing back to HIV. Dr. Lundberger, the picture I got from your description was that you had a facility that was able to continue delivering care, but people weren't showing up for it. And I have sort of one technical question about that, and then I wanted to ask Dr. Van Gutsum his view as well. The technical question is, did you see any change in HIV-related mortality as opposed to Ebola mortality? I mean, were people getting sicker? Were they having any effect? Was it having any effect on their outcomes? The more general question is, how widespread is this phenomenon? How badly affected is HIV care outside your region, but across the whole region? And I ask both of you to comment on that if I can.
Thank you for the question. So one of the main challenges is actually to keep healthcare facilities functioning, and that was one of the things I was much working on in 2014. We are not, among the patients that were followed at our center, we didn't see an increase in mortality, but it is very likely that among the patients that did not turn up and therefore were not diagnosed with HIV, that there was an increase in mortality, though this was not something that we could measure in our study because that was in the community. So it's actually a pointer to, our study is a pointer to a hidden problem in the community. The same is true about TB and malaria and other diseases for which people were not getting treatment and therefore are likely to have died more frequently. As to other healthcare facilities, I know in our region that many other healthcare facilities had problems with offering continuous services because of staff either dying from Ebola or fleeing the hospital or such kind of problems, in addition to the fact that patients were not turning up. So those were two problems which were compounding the effect. But there are no, as far as I'm aware, no data from other structures in our area as to what clinical effects that would have had.
Yeah. There's a recent study on HIV attendance rates in Liberia showing a 50% drop. And that's, I think, a very optimistic estimate. When I was in Monrovia, most primary care clinics were closed in Liberia, and all secondary care facilities were closed. So if you had anything else than Ebola, and you were not rich enough to attend private health care, you would have no health care at all. And that was from pregnancy related to malaria to trauma or HIV and TB. In Sierra Leone, I think it's pretty much the same. Guinea managed to keep their health services more functioning than Sierra Leone and Liberia.
Okay, thank you. I'd like to thank the panelists and thank the press and Mark for arranging all this, and have fun at the meeting. Opening session, 5 o'clock.